All right, Joanna, thanks so much again for joining us.
It is my pleasure to be with you all tonight. Thank you so much for having me. I happen to be in Chicago this evening, but I am actually born and bred from Los Angeles. So it is nice to be with you all. We were asked to talk tonight about navigating insurance and finances, and we do that almost every day at Triage Cancer. And so my goal for this evening is to give you some of the tips and tricks that we think are most helpful for people in navigating insurance and dealing with the financial impact of a cancer diagnosis. So I do just want to mention, if you aren't familiar with Triage Cancer, as Allison mentioned, we are a nonprofit organization that provides education on all of the legal and practical issues. And that spans a lot of things, but a lot of those things are things that we don't think of as legal issues, like access to health insurance coverage. So at Triage Cancer, our goal is to provide free education, and we do that in lots of different ways. So we have lots of different resources and lots of different formats, whether it's animated videos and podcasts to our guides and Cancer Finances Toolkit. You can find all of those things on our website, and I'll point to some of those resources throughout the presentation. When we talk about finances, it really brings up the issue of financial toxicity or financial hardship. And those are terms that researchers have coined over the years to describe the financial impact of a cancer diagnosis. And that term, financial toxicity, was coined back in 2013, but here we are, 11 years later, still talking about it as a serious practical problem of a cancer diagnosis, because it's not an easy thing to solve. And part of the reason it's not easy to solve is that there are a lot of contributors to financial burden. And at Triage Cancer, we think the actual number one contributor to financial burden is having inadequate health insurance coverage. So even beyond not having insurance, making sure you have the right insurance for you. But also knowing how to use your insurance effectively is important to minimizing those bills and the financial impact of cancer. But there are other things that contribute, like changes in employment. Your existing financial situation is going to contribute to what impact a cancer diagnosis has moving forward. And then all the things that normally happen in life that impact our finances, like getting married or divorced or moving or graduating from school, all of those things can also have an impact on your finances. But I want to focus tonight on health insurance. And unfortunately, as we try to educate people on health insurance, what we've learned over the years is no one really understands health insurance. And it used to just be sort of our anecdotal experience in providing that education, but now we have some data to back it up. Only 4% of Americans could actually define the 4 key terms used in health insurance. That means 96% of Americans can't terms. So it's not surprising then that 40% of people think that they can accurately pick the health insurance plan that's best for them. I would say they're probably overconfident if they don't understand those words. So really the bottom line is, if you feel like you don't understand health insurance, you're absolutely not alone. This is a problem for everyone. And I think that when we talk in the community, we say all the time that this is information we all should have been taught in high school, because we all need to know it, but no one ever taught it to us. And that's really what Triage spends a lot of our time doing, is providing education on the things that everybody should really know. So if we're looking at those terms, the first term that I want to mention is what it costs us to actually have our health insurance coverage. We pay each month a fixed dollar amount that's called our premium. And we pay our monthly premiums even if we got no medical care during the year. It's just what we have to pay to have the health insurance. But then there are specific costs that we pay when we actually use our health insurance coverage and get medical care. And the first is our deductible. It's a fixed dollar amount that we have to pay first before our health insurance coverage kicks in every year. So it's our annual deductible. But that's different from a copayment. A copayment is a fixed dollar amount that we pay each time we get certain types of care. So you might have a $20 copayment to see a primary care physician, where you would have a $50 copayment to see a specialist, like a dermatologist. And that's different from a coinsurance or cost share amount. Those are two terms that mean the same thing. It's the difference between what insurance companies pay for our medical expenses and what we pay for our medical expenses, and it's a percentage. So if you have an 80-20 plan, the plan is going to pay 80% of your medical expenses, and you're responsible for 20% of your medical expenses. But the most important thing that anyone should know about their health insurance coverage is their out-of-pocket maximum. Because in a worst case scenario, it's the most that you're going to pay out of pocket for your medical expenses during the year. And it's a math problem. So the way that you reach your out-of-pocket maximum is by adding up what you pay for your deductible, plus any co-payments that you make during the year, plus any co-insurance amounts that you pay during the year. And that helps you reach your out-of-pocket maximum. And when you do reach your out-of-pocket maximum, then your insurance kicks in at 100% for the rest of the year. So you could have a $1,000 out-of-pocket maximum, or you could have a $15,000 out-of-pocket maximum, depending on the type of plan that you have. Now, I want to give you an example of how this actually works, and I want to share Dan with you. So Dan has a plan that has a $2,000 deductible. It's an 80-20 plan, and he has an $8,000 out-of-pocket maximum. So he spends the week in a hospital, and he walks out with a $102,000 hospital bill. But assuming he's had no other medical expenses during the year, how much does Dan actually have to pay of that hospital bill? Well, first he pays his $2,000 deductible, which leaves $100,000 left of the bill. But he has an 80-20 plan, so the insurance is going to pay 80% and he's responsible for 20%, which leaves him with a $20,000 bill. But how much does he actually have to pay of that $20,000 bill? Well, he has an $8,000 out-of-pocket maximum. He's paid $2,000 for his deductible. So that means he has $6,000 left that he has to pay of that bill to reach his $8,000 out-of-pocket maximum. And then his insurance will kick in and pick up the rest of that $20,000 bill. Now, I'm absolutely not suggesting that $8,000 isn't a lot of money, but it is better than the $20,000 bill that he would have had to pay if he didn't have an out-of-pocket maximum. So everything I just explained is actually in one of our animated videos on health insurance basics. So if you wanted to see it again, you could do that there. But when we talk about the law, we always say the devil is in the details. And you have to understand how your out-of-pocket maximum works for your specific plan. So you might have a family plan where there's an individual out-of-pocket maximum and a family out-of-pocket maximum. If you have a marketplace plan, that's actually the most protective for consumers, because out-of-pocket maximums for marketplace plans have to include deductibles, co-payments, co-insurance amounts, not only for medical care, but also for prescription drugs. Some employer plans are allowed to carve things out. So you might find an employer plan that says, we're not going to let you include your deductible to help you reach your out-of-pocket maximum, or we're not going to include the deductible or the co-payments to help you reach your out-of-pocket maximum, or we're going to give you an entirely separate out-of-pocket maximum for your prescription drugs. So again, it's important for you to know how your out-of-pocket maximum works for your particular plan. Now, for insurance plans, whether it's a HMO or a PPO in private insurance, whether it's an individual plan or an employer plan, or maybe you have a Medi-Cal managed care plan or even a Medicare Advantage plan, those all have networks of providers, specific groups of providers that contract with your insurance company for a specific rate. And that rate is referred to as the allowed amount or contracted amount for each type of service. So they agree ahead of time to accept specific amounts from that insurance company. So in-network providers have to accept those contracted amounts, whereas out-of-network providers are not contracting with the insurance company. And if you're going to an out-of-network provider, you're likely not going to have that care covered at the same rate as if you went to an in-network provider, which increases your out-of-pocket costs. There are also a few terms related to prescription drugs that we want people to understand. And the first is the formulary. It's the list of drugs covered by a particular plan. And formularies are broken down into different levels called payment tiers. And depending on where the drug falls in the payment levels, tells you how much you actually have to pay out of pocket when you go to pick up that prescription. So tier 1, for example, could include the cheapest generic drugs, and you might pay a $5 copayment to pick up that prescription. For example, if you need an antibiotic, that would be a good example. Then at tier 2, you might include the expensive generic drugs and preferred brand name drugs where you're not paying $5, but you're paying $25 per prescription. And then at tier 3, you have more expensive and brand name drugs, and there it might be $100 a copayment per prescription. Tier 4 is where we find specialty drugs and drugs that are newly approved by the Food and Drug Administration. And here, we're typically not looking at copayments, we're looking at coinsurance amounts, where we're paying a percentage of the cost of drugs. And unfortunately, specialty drugs include many of the cancer-related treatments that people receive. And if you have a treatment, for example, that costs $10,000 a month, you're not paying a $100 copayment, you're paying 20% of that $10,000. So that's a considerable price difference. And so understanding how the formulary works for your plan is important, but it's also something to look at if you're shopping for new coverage to see how a formulary is broken down by that particular plan, because then you can make different choices as a consumer. Now, in the United States, there's only 3 places where we get our health insurance coverage. We're either getting it directly from an insurance company, we're getting it through the government, and by that, I mean Medicare, Medicaid. In California, that's Medi-Cal. State or local programs, TRICARE for the military, VA health, all of those are programs run through the government. But about 50% of people in the United States actually get their health insurance coverage through an employer. So it's very important, especially when you're thinking about reducing your costs, to understand insurance options. And you can't really make an educated decision about which option is going to be best for you and cost you the least until you actually know what all of those options are. And so at Triage Cancer, we have a lot of resources to help people understand their insurance options and then how to actually make some choices among those options and then how to use insurance effectively. And I'm going to give you a couple more tips about those topics tonight. So whenever we're looking at health insurance options, we're always looking for opportunities to lower costs. Where can you tap into financial assistance or lower your potential premiums or out-of-pocket costs? And I want to give you some examples. And the first is with employer-sponsored health insurance. If you're in a position where you're leaving your job, you're losing your job, or you're reducing your hours, or you're a young adult who ages out of your parents' health insurance plan, those are all potential reasons why you would qualify for COBRA. And COBRA is a federal law that lets you keep your employer-sponsored plan for an additional period of time, between 18 and 36 months. Now, California actually has a state law called CalCOBRA, which, regardless of the reason why you qualify for COBRA or CalCOBRA, you actually get to keep it for 36 months, as long as your employer is not self-insured, excuse me. So COBRA only applies to employers with 20 or more employees. The CalCOBRA law applies to employers with 2 to 19 employees. The benefit to COBRA is you get to keep your same health insurance plan that you had at work, The downside to COBRA is that you are now responsible for paying the full amount of what your employer paid for that health insurance plan, including a potential 2% administrative fee. And I always say that we don't appreciate what our employers pay for health insurance until we have to write that check ourselves. But because COBRA can be expensive, there is a program available called the Health Insurance Premium Payment Program, or HIP. And this is actually a Medicaid program where every state can choose whether or not they want to have this benefit because it's an optional Medicaid benefit. California actually does. And California's Medicaid program, or Medi-Cal, will actually pay your group health insurance premium for you if you qualify for Medicaid. And it's actually cheaper for them to pay your COBRA premium for you rather than to pay for all of your care through the Medi-Cal program. So when you do the math, most of the time, the state paying your monthly premium is definitely going to be less than paying for all of your care through Medi-Cal. And this is a good way to actually have your COBRA premium paid for you. And to be able to keep access to your COBRA plan that you have through your employer. So you don't have to worry about changing providers or worrying about the formulary and whether or not it will cover your drugs or not, because it's the same plan. So this is one of those well-kept secrets of our healthcare system that can help offset the cost of COBRA coverage. There are also options to buy private health insurance coverage through state health insurance marketplaces. And these marketplaces are effectively insurance shopping malls. It's one place where you can go to find all of your private insurance options available to you in your state and to see if you qualify for Medi-Cal. And in California, it runs its own marketplace. And in California, the state marketplace is called Covered California. There are some actual benefits to buying a plan through the marketplace as opposed to buying an individual plan outside of the marketplace. The first is that there are many consumer protections available if you buy a marketplace plan. One of those protections is that the out-of-pocket maximum is not allowed to be more than $9,450 for an individual. Now, that's pretty high. It's gone up over the last 10 years, but it is still sometimes less than what we see in employer plans. And so the fact that there is a cap on what that out-of-pocket maximum could be is valuable. It doesn't mean that it will be that high. It just can't be higher than that. The other major benefit to buying a plan through the marketplace is that you might qualify for financial help based on your income level. And there's two types of financial help. There are premium tax credits, which lower what you pay for your monthly premiums, depending on the plan that you choose. So if you choose a plan that is $300 a month and you qualify for a $100 premium tax credit, you only actually pay $200 a month for that plan. Then there are cost sharing subsidies, which lower what you pay for your out-of-pocket costs, like your deductibles and your copays and your coinsurance amounts, depending on the type of plan that you choose. When we talk about the marketplace, it is variable. So what this chart is showing is the income levels at various levels of the federal poverty level. And the financial assistance for the premium tax credits goes up to 400% of the federal poverty level. So if you have a family of four making under $120,000 a year, you're actually going to qualify for some type of financial assistance to buy a plan in the marketplace, which is actually the majority of people in the United States. However, because of COVID, there were some federal laws passed that added financial assistance to the marketplace. And it added more financial assistance for everyone, but it really provided a lot of help at the lower end of the spectrum. So for individuals who have a household income between 138 and 150% of the federal poverty level, you can actually find a plan in the marketplace for $10 or less per month. And that is pretty significant. And we want people to know this because sometimes we come across individuals who maybe 10 years ago looked at the marketplace for health insurance options, and the premiums were much higher. And so they kind of wrote off the idea of the marketplace as an option for health insurance. And we want people to know that things change. They change every single year, but this is an important aspect. That federal law that added financial assistance also did that at the top end of the spectrum. So for families that have a household income over 400% of the federal poverty level, previously they didn't get any financial assistance. But the truth is that you might make more money, but your cost for buying health insurance might be a large portion of your income. And this financial assistance actually lowered the household income level to 8.5% for the cost of purchasing health insurance. So basically, if it costs someone more than 8.5% of their household income to buy a plan, they get financial assistance to drop that cost to 8.5% of their household income. As I mentioned, these were COVID-related laws, and unfortunately, they are time limited. So this additional financial assistance only lasts through 2025. Excuse me. So we don't know what Congress is going to do beyond the end of next year. But going into an open enrollment in the fall, people can still buy plans for next year and qualify for that additional financial assistance. Now, turning to Medicare, Medicare is the federal health insurance program that actually covers 1 in 5 people in the United States. And in order to be eligible for Medicare, you have to be 65 years or older and be eligible for Social Security retirement benefits. Or you have to have been receiving Social Security disability insurance benefits. Excuse me, very sorry. You have to have been receiving Social Security disability insurance benefits for 2 years before you get access to Medicare. Or if someone has end-stage renal disease or ALS, those are 2 medical conditions that automatically qualify you for Medicare. And Medicare is complicated because it's actually broken up into different parts of coverage. And when someone is eligible for Medicare, there's really 2 different lanes that people can drive down in terms of deciding how to access their Medicare coverage. So I want to give an example of those 2 options. So first, in lane 1, someone could go with Original Medicare. Original Medicare is a fee-for-service model, meaning that you can go to any provider across the country who accepts Medicare. There is not a limited network of providers. And Original Medicare includes Part A of Medicare, which is hospital insurance and covers hospitalization, as well as hospice and some limited skilled nursing facility and home health care and nursing home care, but very limited. And then it also includes Part B, which is referred to as medical insurance. It's really the core of Medicare coverage. And it covers things like outpatient care, doctor's visits, lab work, imaging scans, durable medical equipment. It even includes IV chemotherapy. So all of that is included under Part B. Now, Part B is an 80-20 plan, and there is no out-of-pocket maximum, which means that you pay 20% of the cost of care under Part B all year long. Part A and Part B also does not include prescription drug coverage. So if you want prescription drug coverage, you actually have to decide, do you want to buy a Part D plan? Do that from a private insurance company. And so Medicare Part D is what covers that prescription drug coverage, but you choose to buy that plan from a private insurance company. And each company provides different benefits and charges different premiums. But in this particular case, you now have a lot of potential out-of-pocket costs, including that 20% of Part B. So some people decide to buy a Medigap plan. And Medigap is supplemental insurance that you buy from a private insurance company that picks up your out-of-pocket costs. So that is where lane 1 ends. Lane 2, on the other hand, is referred to as Part C of Medicare, or a Medicare Advantage plan. And this is where you're getting your Medicare coverage through a managed care plan that you buy from a private insurance company that includes your benefits for Part A and Part B. Now, about 90% of Medicare Advantage plans actually includes prescription drug coverage as well. But if it doesn't, then you're also going to want to decide if you want to pick up that prescription drug coverage by buying a Part D plan. But that's where lane 2 ends. And the reason why is because there is an out-of-pocket maximum for Part A and Part B through a Medicare Advantage plan. And this year, the out-of-pocket maximum is $8,850. That's not including the prescription drug coverage. That's just for care under Part A and Part B. So you don't get to buy a Medigap plan on the right-hand side in lane 2 because it has an out-of-pocket maximum, whereas lane 1 does not have that out-of-pocket maximum. So I've given you a very quick high-level overview of Medicare options, but I want to talk about a couple of things that are coming down the pike. So this year, the way that a Part D plan operates has changed significantly. And so I want to talk to you about that and the changes that are coming next year, and then talk about some of the ways that you can save money related to Medicare specifically. So the way that a standard Part D plan works this year is that there is a deductible for prescription drug coverage, which cannot be more than $545 this year. So after you pay your deductible, then you enter what's called the initial coverage phase. And during this phase, you actually pay 25% of your prescription drug costs until your total out-of-pocket drug costs reach $8,000. Then you enter what's called the catastrophic coverage phase. And this year, for the first time in Medicare's history, there's a cap on what you pay for your total out-of-pocket drug costs, where when you reach that $8,000, then you pay nothing for the rest of the year. But what is significant about this is that the details matter, because even though the total out-of-pocket drug cost is $8,000, if you're taking brand name drugs only, it's actually not $8,000. Your total out-of-pocket cost that you would pay is $3,333. Now, the reason why is because you get credit for the discounts that drug companies pay for the brand name drugs, which is 70% of the drug costs. So you're paying 25% and you get credit for the 70% discount from the drug company. So you're actually getting 95% credit of the drug costs, which means your actual out-of-pocket costs are $3,333. Now, I know that's a lot, and it's, for me, it's later in the evening and the math is a little complicated, but the truth is if you do the math, that's what it actually comes out to be, what you are paying out of pocket if you have brand name drugs that you're taking. But if you are only taking generic drugs, this year you will have to reach the $8,000 in total drug costs to reach the out-of-pocket maximum. So it's actually kind of created an interesting situation where if you're taking brand name drugs, you're going to end up spending less this year than if you were taking generic drugs. But this is all very short-lived, because come next year, it's all going to change again. In 2025, there will actually be a $2,000 out-of-pocket drug cap, so that you are not paying more than $2,000 over the course of the year for your prescription drugs out of pocket, which is pretty huge. So we go from no cap in 2023 to an $8,000 maximum in 2024 to a $2,000 maximum in 2025. And the other thing that will happen come January 1st is that if you are taking an expensive drug, you might have to pay that $2,000 in January. Moving forward, you can actually spread out the cost of that $2,000 over the course of the year. And you will be able to sign up for a Medicare prescription payment plan that instead of paying $2,000 in January, you would actually pay $167 a month over the course of the year. So you get to create basically a payment plan for your out-of-pocket prescription drug costs, which makes it easier for people to actually pay that than having to pay the $2,000 in one lump sum in January. We don't have the final rules yet on how these payment plans are going to work next year, but we expect them any minute. And when we do, we'll be sharing information on how you actually sign up for these plans moving forward in January. Now, there are some programs that help with the out-of-pocket costs and sometimes the premiums for Medicare Part A and B. And they're offered through Medicare Savings Programs, or MSPs. And there's actually 4 different types of MSPs, and each one has a different income and resource or asset level that you have to have in order to qualify for these programs. But they can help pick up the premiums for Part A and Part B, as well as potentially the out-of-pocket costs like the copayments and coinsurance and deductibles for A and B. So these programs you can find more about using the Triage Cancer Quick Guide, but you can also contact Medicare to find out if you qualify for one of these programs based on your income level. Specifically related to prescription drug costs for Medicare, we have the Low Income Subsidy, or the LIS program, also called the Extra Help program. There's 3 different names for the program, but this picks up the out-of-pocket costs and some premiums for Part D, or prescription drugs. This program is available to anyone with a household income up to 150% of the federal poverty level. And if you qualify, you may be automatically enrolled, but if you think you might qualify, you can also contact Medicare to sign up, and it will lower what you're paying for your drugs, your premiums, and your deductibles. If you don't qualify for the Extra Help program, you may also be able to tap into the State Pharmaceutical Assistance Program, which isn't something that's available in every state, but it drug costs. So I want to turn for a minute to how you actually compare your options once you've figured out what they are. And this exercise is useful if you're comparing marketplace plans, if you're comparing choices that your employer gives you. You can compare what your employer gives you to what's available in the marketplace, and then you can also compare Medicare Advantage plans. Excuse me. So here we have 3 plans. One is a bronze plan at $200 a month with an $8,000 out-of-pocket maximum. A silver plan at $275 a month and a $6,000 out-of-pocket maximum, and a platinum plan at $400 a month with a $2,000 out-of-pocket maximum. So once you've narrowed down your plan options and you're looking at these 3 choices, can you tell just by looking at them how much the plan is actually going to cost you by the end of the year? And the answer is no, you can't tell just by looking at them. You actually have to do the math. And when we do the math, we actually do the math with the assumption that you are going to hit your out-of-pocket maximum, because when we're talking about the cost of cancer care, the likelihood that you're going to hit an out-of-pocket maximum is pretty high. And so when you do the math, you take the monthly premium and you multiply it by 12, because that's how much it will cost you to have the plan for the year. And then you add that to the out-of-pocket maximum, because that's the most that you're going to pay out of pocket for your medical care during the year. And that's what gives you the total out-of-pocket cost. So here, when we do the math across the 3 plans, it turns out that the platinum level plan actually ends up saving us a couple $1,000s by the end of the year. even though we kind of get sticker shock when we look at the monthly premium for the Platinum plan and we think it's going to be the more expensive option. But the truth is that most people don't know what an out-of-pocket maximum is or how it works. And so they're only picking plans based on the amount of the monthly premium. And unfortunately, that's where people get caught, where they have very inadequate insurance with huge out-of-pocket costs. And when we talk about how do we minimize the financial burden of a cancer diagnosis, this is actually the number one way we can do that, by making sure that we have adequate health insurance coverage. But it isn't just about cost. We have to make sure that any plan that we're looking at actually covers our providers and the facilities that we go to and any prescription drugs that we're taking. Because if we don't check, it doesn't cover those things, then it's going to be pretty useless to us. And frankly, going to cost us more because we might have to pay to go to out-of-network providers or pay out of pocket for prescription drugs. So we do have a number of resources to help people actually do the math to pick a plan. We have an animated video that goes over what I just went over, but we also have worksheets to help people do the math. So we have a worksheet that is available for private insurance, but we also have one that is available for Medicare. And we also recommend using Medicare's Plan Finder. If you're in a position to be looking for plans related to Medicare, you can put in your zip code and the types of plans that you're looking for, and it actually will show you all of the plans available to you where you live. And that includes Medicare Advantage plans or Part D plans, or if you're looking for Medigap plans, you can find all of that on the Medicare website at medicare.gov. So in addition to knowing all of your health insurance options and some of the ways that you can save money as you're choosing health insurance, knowing how to use your insurance can also lower costs. And I want to give you a quick example of this. It is not uncommon for people to be in a situation where at some point during their treatment, their insurance company says, we're not going to cover that care. And people actually have rights in that situation. And individuals who have private health insurance have an internal appeal right where they get to go back to their insurance company and ask them to reconsider. But if the insurance company still says no, they now have access to an external appeal. And that means you get to go outside the insurance company to an independent entity, and they get to decide whether or not it's medically necessary for you to get access to the care that your healthcare team prescribed. In California, the agency that actually oversees the external medical review process is called the California Department of Managed Healthcare or the Department of Insurance, depending on the type of plan that you have. And this process is very successful. So that data point on the side is from California, where 60% of the time, people are actually successful if they go through the external appeals process. The problem is that even though this consumer protection exists, nobody knows about it. And I don't mean just patients, I mean providers don't know about it either. And just to give you proof that no one understands that this is a consumer protection, this is a data point that shows that there were 48 million claims denied in 2021, just for consumers who had marketplace plans. 99.9% of people took no for an answer when their claim was denied. Only 0.1% of people actually filed an appeal. And not even to the external appeal stage, just to the first level of internal appeal. So unfortunately, consumers aren't using the protection that's available to them. But what this really means is that 48 million people were denied coverage for care that their healthcare team thought was appropriate. And ultimately, because they didn't use the appeals process, one of two things probably happened. They either didn't get access to the care that was prescribed by their healthcare team, or they paid for it out of pocket. And so when we're talking about how do we lower the financial burden of a cancer diagnosis, the external appeals process is actually a huge contributor to that, because people don't know about it. And so we want people to be aware of the appeals process. And we have a lot of resources to help people understand appeals, not just if you have an individual or an employer plan, but if you have Medicare or Medi-Cal or a VA plan, we actually have information on how you literally go through the appeals process to get access to the care that was prescribed by your healthcare team. Now, turning for just a minute to managing medical bills, we don't generally recommend this strategy as for dealing with bills. Avoidance coping is not a great strategy for medical bills, because if you don't open the bills and you are just hoping that they will go away because you aren't able to pay them, you might actually be losing out on some potential ways to deal with those medical bills. And when we're talking about bills, it generates a lot of pain. You might get a letter or an email from an insurance company saying, we've received your claim. You might get one that says, we're processing your claim. And then you eventually get the explanation of benefits, or the EOB. And this is actually the most important piece of information you're going to get from your insurance company. It usually looks something like this. It has a chart with codes, a description of the claim that your doctor filed on your behalf, and then how the insurance company handled that claim and your responsibility for that amount of the bill. But the key piece of information on the EOB, somewhere it says this is not a bill, because it's identifying it that this is the explanation of benefits, not something that you actually have to pay. The last piece of paperwork that you get is the actual bill from your provider. The problem is that not all this paper always comes in order. Sometimes it comes out of order and creates a lot of confusion. So we always suggest that people wait for the explanation of benefits before they pay any bills, and make sure they match up and that they're correct. You want to make sure that the care that you received is actually correctly listed, and that your insurance company correctly paid for that particular care. So if you have questions about this process, you can always talk to your providers, but you can also call your insurance company and ask questions if your bill is higher than you expected, if things don't match up, if you got the wrong person's EOB, if you see other mistakes. Unfortunately, this is a human process and we make mistakes. And so you always want to just double check that your bills are correct before you actually pay them. If you're in a situation where you actually got care at a hospital, where you were inpatient in the hospital, you might also qualify for what's called charity care. Nonprofit hospitals are required to provide financial assistance to patients in their community. The problem is it's not always well advertised to patients. And so if you've received a hospital bill that you are having trouble paying for, you can actually go to an organization called $4 and you can ask for their help. They will actually look up your hospital's financial assistance program and see if you should be qualifying for that program. And they'll help you negotiate the bills that you've received based on the financial assistance that you should have received through the charity care program. And they do all of that for free. So they're an incredibly useful resource. And then certainly if you get a medical bill that shows that your insurance company didn't pay anything because they're denying coverage, you can appeal those denials. You can also negotiate your bills. If you are in a situation where you cannot pay, you could actually go back to your provider and say, would you be willing to write off a portion of the bill? Or can I work out a payment plan where I pay you money each month? Or maybe they'd be willing to accept a lower lump sum payment rather than a payment plan, because they'd rather have some money than have to get money from you each month over a long period of time. This is actually pretty standard practice in healthcare, and so it's always worth asking to see if these options are available to you. We also have a resource at Triage Cancer called our Medical Bill Tracker. It's a spreadsheet that you can download from our website. And when you kind of zoom in on the spreadsheet, you can see that you can put in your plan information, including the deductible on your plan, and the out-of-pocket maximum. And as you start to add in your medical bills and what you've paid out of pocket for them, it will deduct in the amounts, and there's formulas already built in. So it will tell you how much you still have to go to meet your deductible and your out-of-pocket maximum. One of the reasons this is helpful is that your out-of-pocket expenses for medical and dental care might actually be tax deductible. So keeping good records of what you've paid out of pocket can actually help lower what you have to pay for your taxes or increase your tax return. So there's a financial incentive to actually staying organized as well. And when we're thinking about financial assistance, we always encourage people to think as creatively as possible. Sometimes people think that they need help with their bills or the medical bills, so they only look for financial assistance related to their medical bills. But the truth is, if they qualify for utility assistance, for example, they could take the money that they were paying for utilities and use that to pay for medical bills. So we always encourage people to think as broadly as possible about financial assistance. And on the Triage Cancer website, we have a tool called Cancer Finances where you can actually look up various financial assistance options by type. And you can look up financial assistance for prescription drug programs. And that includes private programs, but it also includes the programs offered by pharmaceutical companies. And when you go to this module, you can find this chart that shows all the companies with all the cancer-related drugs and links to their patient financial assistance programs. So you can link to that directly and get to their website to sign up for that program. So I do just want to say that I've given you a pretty high-level overview of a lot of information, and I know that, but I want you to know that there are places where you can go for more in-depth information, including the events that we host at Triage Cancer. We do have a Triage Cancer conference series. We did one in May, and then the next one is happening in October, which covers all of these topics and more. And then we have a monthly webinar series where we're covering a variety of different topics each month. And if someone still has questions about their personal situation, you can always reach out to our legal and financial navigation program, where you can set up an appointment to talk with one of our team members for free. So this is also a resource available to you. So I'm going to stop there, and then we will take some questions.
Thank you so much, Joanna. That was so helpful and informative. I'm going to go ahead and stop the recording.